Welcome back, everybody, to your El Paso Running Podcast. Whether you're lacing up for your first mile or chasing that new PR, this podcast was created for runners of all levels and to support the wonderful running community that we have. I'm your host for the show. I'm Dr. Maria Fuentes, and each episode we dive into expert advice, inspiring stories, and the latest running trends and local events, helping you stay informed, motivated, and connected. So let's hit the ground running together and continue growing and learning from each other together. So today's topic, I'm going to go straight to the point. I don't have a background for you today because I think it's an important topic that we're going to spend a lot of time that we have like so many questions and we can just go ahead and take forever on this one. But today we're going to be talking about running injuries. I think it's very important for us to understand the biomechanics, a little bit of that physiology behind it. What is happening when we put too much stress to the muscle? Yeah, stress in one sense is kind of good because it's the one that is going to lead us to change. But what is happening when we're not handling that amount of stress properly, right? That it takes us to develop some pain and also like some of these running injuries. So, and it's also important, like, how do I distinguish if it's just like a pain maybe from soreness, or when do I have to actually stop and get some medical attention or advice from experts, right? So this is going to be an important topic. And with me to help me go ahead and talk about this important topic, I have Dr. Liliana De Castro. She's a licensed physical therapist with a strong academic and clinical background in human movement and orthopedic rehabilitation. She completed her undergraduate studies at the University of Texas at El Paso, earning a degree in kinesiology with an emphasis in exercise science and a minor in speech-language pathology. She then went on to earn her doctorate of physical therapy from the UTEP as well, where she gained a clinical experience in acute care, pediatrics, and orthopedic and sports rehabilitation settings. After graduating in May, she began a year-long orthopedic residency through UTEP's Paso del Norte program, further specializing in the evaluation and treatment of musculoskeletal conditions. Dr. Lily is currently preparing for her orthopedic clinical specialist exam, and she's passionate about optimizing performance and recovery for runners and active individuals. I'm so glad to have her on the podcast. I've been her patient before. I have complete trust in her experience, and in her knowledge. So I'm very happy to have her with me today. Hi, Dr. Lily. How are you?
Hi, good morning. I'm good. How are you?
I'm very good. Thank you so much for joining me today. I'm excited for you to talk about this, your area of expertise. As runners, like, this is the worst that can happen for us. And you probably know us. We're really stubborn. Like, we have the pain, even with a stress fracture, we don't care. We're just gonna keep on going. So I'm sure you have to struggle also with that aspect of the mentality and the psychology behind the runner's love for the sport, right? So tell us, what is your experience working with runners so far?
So, I've been a PT for not too long. I graduated in May of 2023, and I worked in an outpatient orthopedic clinic for about a year and a half. And so I got the experience of working with various athletes, not just runners. I worked with tennis players and soccer players that underwent an injury, and they either underwent surgery or they're going the conservative route for their treatment. So yes, it is very true that athletes can be very stubborn, and with good reason, right? Yeah. They love the sport. They want to continue playing. They don't want to miss out on that important aspect of their life. But as a physical therapist, it's my job to give them that education and give them those tools to make the appropriate choices to see, well, is it worth it to go back to the sport immediately, or is it just better for me to wait a little bit, be a little bit more patient, and undergo this conservative treatment or this rehabilitation protocol for me to have better and optimize my performance in the long run, right? So I think that's very important for athletes that are listening to understand that it's really worth it to just undergo the process and trust the process, right?
I think it's very important for us at least to seek an evaluation for something. I think it's better in the beginning to recognize, is it possibly that I'm developing an injury, and just get us an opinion, from an expert, because I feel that we don't pay attention to something that might be minimal, and later on we're going to be carrying that and develop like a full like run injury that is going to completely stop us, right? And pretty much ruin the whole training process that we have so far.
Yeah, and that's exactly it. If you take care of it from the get-go, it may not turn into this thing where you have to drop the sport altogether. And that's why I encourage physical therapy, because you go and seek this professional help, you get evaluated, and it could be a matter of a week or two of just performing, well, not a week or two, it's typically longer, but of minimizing the activity versus now you put it off and now you have to drop it for a significant period of time.
Yeah, right? For sure. And Dr. Lily, okay, so let's just say that I'm a runner, right? And I'm beginning with pain during my runs. When is pain a warning sign? You're going to say always, right? Like in big letters, always. But when is it like a sign for me to stop my workout and just wait, rest, and maybe go and ask for professional help? Or when is it okay, I'll just take a couple of days and just wait to see what happens, let it cool down and get back to my activity? Where is that dividing point of what to do as a runner?
That's a very loaded question, and I'll explain why. It really depends on it, and you'll hear this over and over again in physical therapy. It depends. It depends on, was there a mechanism of injury in the first place? Was there something that happened? You tripped, you fell, you twisted your ankle, you pivoted, and you felt that moment of pain? Or was it just gradual and over time kind of pain? How is the pain presenting? Is it constant? Is it when you start your run? Is it after you have completed your run? Is it during the entire run? The different pain descriptors, right? Is it burning? Is it numbness, tingling? It just depends on a lot of factors. But what the literature says is anything above a 2 out of 10 pain, either during your run or after your run, should be considered a red flag.
That's really low. I think in running, we're very tolerant to pain.
And what I hear over and over in my patients is no pain, no gain, right? So I need to keep going. And that's completely the opposite of what physical therapy is for the most part. Again, it depends on the patient. It depends on the situation. If you're getting a total knee replacement, then I would say, yeah, you're going to have pain, and that's normal. And yes, when you come to the clinic, I expect you to have some sort of pain, right? But if you are a runner that has a patellofemoral pain syndrome, then I would say, no, I don't want it to hurt. And that's what it is like for the most part when patients come to the clinic. No, I'm not expecting you to have pain, and it is not normal. So you need to tell me if whatever we're doing hurts, because it's not right. We need to adjust, we need to modify. There is not a one-size-fits-all program for patients. So, and here we go into the thing where, let me ask ChatGPT about whatever, or let me go onto the internet and search my symptoms, because it's very, very dependent on each person.
Okay, so you're giving us a very low score with a 2, and it probably we go when we have like a 10 or an 8 or a 9, and we're completely unable to walk. That's the point where we leave it up to. All right, so I guess for that we have to make the difference between pain and soreness to begin with, no? So what would soreness be?
Soreness would be the delayed onset muscle soreness, right? When we talk about DOMS is what that means. And basically soreness feels like you just went through a hard workout, you're rubbing out your muscles, and you get that feel-good sensation of rubbing out muscles. This usually lasts about a day or two following the exercise, versus your pain would be, I would say usually, it depends again. For the most part, it would be a little bit more localized, right? A lot of patients, if they have, again, patellofemoral pain syndrome, it's going to be localized to the anterior or the front part of the knee, underneath the kneecap. If they tend to have some sort of ligamentous rupture or disruption, it's going to be localized to the joint line, or wherever that ligament is placed.
Yeah.
Right. You're also going to have swelling. So if it were to be something like meniscus related, so that cushion you have in between both your bones, your femur and your tibia, a lot of times we expect to see swelling, heat, and pain with different and very specific types of movements.
And I think that if we get to see those cardinal signs of inflammation, redness, swelling, heat, that's already big red flag, like something very clearly is happening in your body, right? That this shouldn't be there, like a beginning of an injury. And talking about soreness, I know in in the past, we used to believe that the buildup of lactic acid of strenuous exercise was actually the one to blame for to experience, oh, it's because I have lactic acidosis, right? And that's pretty much because of this hard work that I'm doing, I'm reducing too much lactate plus protons over there, and that is an acidic environment that is producing this soreness. But no, now the research has shown that it's not really the lactate accumulated in the muscles to blame for that soreness. That, like we were saying, the DOMs are also like microscopic tears in the muscle, and already sending some cytokines and other molecules of inflammation are actually giving a warning sign that it's inflammation that is actually happening in your muscle. What should we do when we start to develop some type either soreness or beginning of pain that we don't know what to do? What should be like the primary steps at home to follow?
In terms of soreness, I would encourage you to keep moving. Movement is going to, in terms of going back to the soreness, movement is essential. Continuing to move. Now, remembering and differentiating, being able to differentiate between pain and soreness. If it's causing you pain, I would say make sure that you know, because that's something that I ask all the time and not a lot of people pay attention to, how the pain is presenting, when is it presenting, and really understanding, I guess, the path, right, of when they're experiencing this pain. But going back to your question, continuing to move, stretching it out, cryotherapy or icing would be a pathway to go as well.
So applying the ice, rest, maybe walk it out, that's okay if you have a type of DOMS, right?
And dynamic stretching is also very good before starting a certain movement. Let's say you're going to go on a very light run and you're very sore. You can initiate your workout with dynamic stretching and then finalizing your workout with static stretching.
We don't like stretching, Dr. Lily.
Yeah.
I think that's another issue, right? But I think it's also teaching the runners how to stretch properly and actually take the time before and after to stretch, right?
Right. And not only stretching, but identifying what needs to be stretched, right? Because a lot of runners, they go stretching muscles that maybe don't need to be stretched, right? So really identifying, and through physical therapy, right? A lot of people don't know what muscles are tight, where there is this muscle imbalance. So that's when I would encourage to seek a physical therapist, not only as, oh, I got injured, now I need to see a physical therapist, but also you can contact a physical therapist as a preventative measure. And learning more about your body, right? Where you stand with your strength, where you stand with your muscle length and muscle imbalance.
And I love about PTs that you guys always know, like very, very specific workouts or exercises that you might be training as a runner, some basic strength, right, in the gym, and do your squats and do the basic strength exercises. But I know you guys always have like these very particular or like right on point exercises that we don't know about, and they're just tricks to me that you guys know over there in your clinical setting. Right. What I know, runner's knee, it's pretty much the most common injury I think that we have in runners. Like about 40% of the injuries are related to a runner's knee. Why is that? What is happening?
Okay, so we're going to go back a couple of steps because I would really like to touch at least a little bit on biomechanics, right? And the importance of biomechanics. And yeah, you're right. The knee, about 42% of the injuries related to running are in terms of knee. And then after that would be lower leg and 19%, foot and ankle at about 17%. And yeah, let's go ahead and talk about a little bit of what is going on in terms of the running biomechanics. So we have the gait cycle, right? We have one for walking and we have one for running. And what differentiates the two is that with walking, there's no point in that cycle where both feet are off of the ground, right? In running, we have the floating cycle in which both feet are off of the ground. But other than that, you have your stance cycle and you have your swing cycle. And stance is when your foot is on the ground. Swing cycle would be when your foot is off of the ground and kind of swinging forward to take that next step. And where we see a lot of these injuries, and this is where your form kind of comes into play. And just as a little preface, this is not any medical advice for anybody because, again, it depends on the patient. It depends on the situation. You would need to have that evaluated. But for the most part, what we're looking at in terms of the gait cycle is at the initial contact, when that heel first hits the ground, that's when we get the maximum amount of force going through the body. And again, going back to the different types of running forms. So for those of you that are not familiar with the running forms, we have the heel, heel strike, then we have the forefoot strike, but we also have the midfoot strike. Right? So heel strike, you land with your heel and your foot kind of just rocks forward. Midfoot is when your heel and the ball of your foot kind of step at the same time, and forefoot, you're kind of hitting with the ball of your foot. Now, in terms of this, when we look at the literature, most of the injuries happen in runners that have heel striking pattern, and that is because there is a lot of tension going through that knee at that point in time. So a lot of the times as physical therapists, we analyze this gait and we analyze on how we're stepping. We're analyzing the cadence, which basically means how many steps you're taking per minute and the length of those steps that you're taking.
What is ideal cadence?
Ideal, there's different depending on when you're looking. Typically the higher cadence will be better than a lower cadence. Why? Because if you have a lower cadence, you're overstriding. When you're overstriding, you're tending to hit a little bit more with that heel.
Okay.
And again, it depends on the person. If you've been heel striding this entire time and you've been fine with it, and there's really no reason for us to go there and change it and force you to be getting midfoot or forefoot pattern. If it's working for you, it's working for you.
And that was my question. Is it worth? Because I know there's research before that they were trying to put athletes to train them how to do the proper running form. And some other researchers say it's not worth it. You should stick to your form. You and your experience, of course, that's your area of expertise. Is it advisable to try to make changes in your running form to improve, of course, your performance or to prevent injuries? Is there like other possible reasons?
In short, no. I don't think it's necessarily worth it unless you're trying to attain this very specific goal. In that case, I would say take it step by step. You don't want to go ahead and change all of these things all at once and then continue with the same, I guess, path that you've been running, the same hills and the same speed and the same pace. I wouldn't go and change a whole lot and then go into your normal, I guess, pacing, and you have to come back a little bit and take it step by step. And again, that starts first with knowing where your deficiencies are and knowing where you can improve. But yeah, a lot of the research says it's not advisable to change your running form. Unless there's an injury, then yeah, maybe looking at where the injury is coming from, because a lot of times, like I said, the research says that heel stepping pattern is one of the main reasons for that, just because it has a lot to do with that vertical and horizontal forces that are going through the body.
And I guess, and I'm sorry if I make an interruption here, I guess this is where also factors like wearing the right type of shoe can also impact not only your running form, but also, I guess, based on what you're telling me, how your foot lands, the type of shoe then might have an impact on developing an injury as well. I know we're like right now we're using the carbon plated shoes. Is that also like a risk factor, like if you're running too much with this type of shoes?
It could be. And again, it's very dependent on the patient, because if you have overpronation or oversupination of your foot and it's not being compensated by something, it could lead into everything up the chain. I always tell my patients, you are connected. Just because your ankle hurts does not mean it doesn't come from your knee, or it does not come from your hip.
All the way from your hip.
And that brings me to an important point. A lot of the times people neglect their hips. I don't know what it is about hips, but it is very neglected in terms of strength training. And that's what we see with a lot of the things that we're going to talk about today in terms of, again, patellofemoral pain syndrome is one of them, right? And patellofemoral pain syndrome, not all the time, but a lot of the times can be an issue with the hips, right? And a lot of the things that I'm going to talk about today come down to your gluteus medius muscle. Your gluteus medius muscle is a hip abductor, and what that means in layman's terms, it kind of brings your leg out, right? Like you're doing a side kick. That's the function of that muscle, and it helps stabilize your pelvis. So you've seen models on the runway, right? When they're walking and then their hips are kind of moving
up and down
like this. As physical therapists, obviously that's purposeful. They do that because that's kind of like how the walking is for models, but we as physical therapists are like, oh no, that's a very weak gluteus medius, right? Because it's not stabilizing the hips to stay in this, I guess, centered, right? It's moving up and down, also known as Trendelenburg gait. But this gluteus medius muscle is very important, not only in terms of the strengthening component of it, but the endurance of it. And especially when talking to runners, I always emphasize the importance of strengthening hips, but also the endurance aspect of it. And especially if, you're a long distance runner, you're a half marathoner and full marathoner. So you're expecting your gluteus medius to be working that entire time. So it's strengthening with that endurance component.
Yeah, hips on live. So pretty much, and if you go back and check the anatomy, all the muscles, they go from the hip all the way to your knees, and even sometimes they're connected all the way, like you're saying, to your ankles. So I feel like, and I learned that actually from you as your patient, right? Like if you have weak hips, it's just gonna feel like it's gonna ruin the whole thing. So you really have to work on those hip muscles, right? Because everything comes from there. From the power to start like bringing your quads up and doing that, getting that running to the downhills to running uphills. All this strength is gonna come from your hip, from the hips. And I know when I was going through these RCA coaching certification, it's a funny example, but they were saying like in the hips, imagine you have like a bowl of cereal that when you're running, that's your hips. You don't want that bowl of cereal be moving too much because you're gonna pretty much drop everything to the side, right? So you gotta make sure that your hips are stable, they stay in place. And like they were saying, imagine holding, and this might be funny, right? Imagine like $100 bill in between your butt and hold it tight and hold that hip tight. That's how you should be running. So everything there should be actually have enough strength and be stable in order to help you with a proper running form.
Right, and that's when core comes in, and that's when a lot of the hip neuromuscular re-education comes in. And so going back to that patellofemoral pain syndrome, I'm sure a lot of your listeners are familiar with the Q angle, right? So it's that angle that is formed by the wideness of your hips and down into your knees. And basically, the wider that Q angle, or the bigger the difference between one side and the other side, can be a risk factor for running injury, specifically patellofemoral pain syndrome. So what is patellofemoral pain syndrome? Basically, this is a pain that you'll feel, again, in the anterior aspect of that knee, underneath the kneecap. And I like to think of this as like a rubber band. I don't know if you've ever held like a hair tie rubber band in between your fingers and then you pull it. That's kind of how I like to think of patellofemoral pain syndrome. It's this very repetitive movement and this tension on this tendon, and it's causing it to have pain, be inflamed, and I guess be opposed to this movement. And so a lot of the times I tell patients hip strengthening is vital. Quadriceps strengthening is also super, super important, but not just the strengthening component, but strengthening in the pain-free range is very important. So squats, you can squat, but you have to keep it at a pain-free range. And then depending on the type of contraction, muscle contraction, we have eccentric, concentric, isometric, plyometric, all that. Well, plyometric is eccentric, but depending on the muscle contraction, you want to be careful to not be doing a lot, depending on the phase too, right? If it's very acute, you want to watch out. You want to maybe hold it to the isometric contraction to where you're strengthening without your muscle really moving, right? Isometric.
And I guess just to put a break here to explain a little bit eccentric, because for all of us, eccentric will be like extension of your muscle. It's like when you're doing like a bicep curl and you're extending, you're bringing the weight down. That will be eccentric. If you just leave it like that and you just hold in resistance, that will be iso, right? It will be like isometric. You're just leaving that contraction. And then when you're bringing it towards you, you're pretty much shortening the distance of the muscle, right? That will be concentric, right? Type of contraction. So just to clarify those terms here.
Right. And in terms of the acuity, right? So when you have a very acute condition, when you first start getting the symptoms of patellofemoral pain syndrome, you want to focus on the lesser intense type of exercise. And again, it depends on the injury. But if it's very acute, you want to focus more on the isometric component of strengthening. And then little by little move on to now we're doing concentric. Now we're shortening the muscle, and then eventually getting into your eccentric, which is strengthening but in the lengthening phase component of the muscle, and eventually getting into your plyometrics and higher impact, higher intensity type of exercises. So yeah, that's basically with patellofemoral pain syndrome what you can expect going into a physical therapy clinic. You're going to get evaluated in terms of core, hip, knee, even ankle, to see your stability in your ankles and the endurance, right? You can be expecting to get the gait analysis. So your physical therapist is going to watch you running on the treadmill from the side view and also the back view, so that we can analyze how your hips are moving, how your knees are moving, and how your foot is planting onto that. And then from the back, again, going into the hip movement from the side to side, seeing if gluteus medius is being activated, and keeping those hips stable. So yeah, patellofemoral pain syndrome is very common, and typically we see it in females more than males because...
Oh, really?
A lot, and you'll find that a lot of the injuries are more common in females versus males.
That's another negative point for us, because we were talking in other podcasts, the influence that the different hormonal changes during the menstrual cycle has on our performance as well. And now you bring us about runner's knee being also more common in women.
Yes.
So
I'm sorry to break it to you, but as women, just for being women, have a little bit of...
Is there a reason for that?
Yes, particularly going back to the Q angle, women tend to have wider hips.
Okay.
Right? And so it kind of makes this angle a little bit more noted and causing a little bit more of that tension in the patellar tendon.
And I was going to go into maybe something hormonal like vitamin D deficiency, or maybe other factors that could play in later stages of life.
Yeah, it could be. And also types of medications that you're taking. Yeah, could be. I'm reading a book actually on the effects of the birth control pill. And there's a lot of things that pill does in terms of not only physiological, but mental and hormonal and all types of stuff, and how it affects women in every which way.
Interesting. Which one is that?
I have to get back on you on that. Yeah, because I think it's the effects of the pill. I forget the author's name.
Well, you can send it over and I'll also go ahead and share it here.
It's a really good book that talks about the effects of the...
And talking about that, I know it's very common for... This is where I'm going to become an advocate for the kidney, right? It's very common for runners and everybody that, I have pain. I just pop into Advils or to Tylenols and just, that's it, right? And continuing. I think it's very important to be careful to not also overtaking NSAIDs, right? Or non-steroidal type of anti-inflammatory drugs. This is where it comes the pros and the cons. It looks like taking a couple of Advils to be very naive, in one way to reduce pain. But also, for example, for runners, it can be not very good for your kidneys, especially we're dehydrated. We need water. We're running, especially in the heat over here, in the hot weathers that we have in El Paso, right? Taking too many Advils also is not going to be very advisable and too friendly to your kidneys. So you have pain, it's better just to get evaluated and make sure you're in the right path.
Right, and that goes also for steroid injections. A lot of time I get asked should I go get a steroid injection? And I'm always well, I guess you could, right? But then a lot of times people love the idea of the easy,
quick fixes,
quick fixes, and they get very comfortable with that. So instead of undergoing this program and this protocol, they're I'll just get a steroid injection. And what they don't realize is that over time, or they keep getting the steroid injection, keep getting it, that actually weakens a lot of your tendons, right? And by tendon, I mean it's the tissue that is from your muscle that goes onto the bone, right? So that's that part that holds your muscles tight to your bones.
That is true. It had an adverse effect on your tendons. It produces tendonitis. Yes.
And that's going into Achilles tendinopathy that I bring with you today. We see it in a lot of athletes and runners, right? Now you're running, you're feeling good, you're feeling fine, and 1 second to the other, bop, and there goes the Achilles tendon.
True. That's very true. I'm glad that you brought that up.
And so that's
We have that
to consider.
Achilles tendinopathy. That's another common one. And most of these also like muscles and tendons. If you put too much stress on us, we can even go from something simple as a muscle strain to even a stress fracture, right? To
Right.
the constant friction and the constant stress and for
Right.
not knowing how to come up with the volume properly.
Yeah, and that would be more for medial tibial stress syndrome,
Okay.
or also known as shin splints.
That's another one.
But shin splints is that condition where the adherence of the muscle and the tissues onto the bone. It's this constant like pull and tug onto that cortical part of the bone that causes that shin splints, right? And this can eventually, if not treated, can eventually lead into a stress fracture. So we need to be very careful in noting what this feels like. And a lot of times the medial tibial stress syndrome, you'll feel it in your shins, right? So the anterior part of your tibia, depending on what muscle is involved, you'll feel it in the anterior portion of the tibia, or more towards like that middle ankle bone that you have here on the medial aspect of your ankle, depending if it's posterior tibialis or it's anterior tibialis related. So with that, a lot of stretching, a lot of times people come in and get dry needling for it, which I'm not a super fan of all of the passive modality type stuff. Yes, it can be beneficial when we're going through like a strengthening program, right? We never really want to do passive types of interventions just on their own.
Okay, and I'm glad you're bringing up this point because that's another one. That's another thing we commonly do. We instead of focusing on strength and devoting our time on having like a good strength program to work specific muscle groups that will help us prevent injuries, we tend to go to these, you were saying, passive modalities. But we love going for dry needling. We love for deep tissue massages. We love getting, what other things do we like? Like
And the
some of those things
ultrasound.
and the ultrasounds. Yeah. So based on what you're telling me, are those not too much recommended to be doing them?
It depends on the modality, for one, and for two, it depends on if you're using the modality along with another treatment. It really, again, it depends on the physical therapist. Here, it's when it depends on the physical therapist and what they preach, right? There's a lot of very manual-based physical therapists that love to do the joint manipulations. They love to do the deep tissue massage. They love to do dry needling and all of that. But that's very passive, right? You are the patient going there, sitting there, and you're getting something done to you. But on the other hand, there are also very exercise-based physical therapists that use that as in conjunction with the therapy and the treatment. And I consider myself more of an exercise-based physical therapist that I use those passive modalities in conjunction with my treatments.
Because I really think that the way to go, I mean, understanding like the mechanical stress and everything, is to really work on exercise, to really solidify and have like a strong foundation that will help you continue pushing your body or to the demands that you're demanding for your body. Like, so you need to have and work on your exercise. I think this dry needling and other modalities, excellent, but like you're saying, like to help you through the process, but not as the main one to be going back and forth to it. I see a lot of runners just going to dry needling, I don't know, like every week. Is that advisable or is that contraindicated?
Know that there's not necessarily anything wrong with it, but all of these passive modalities are going to be very short-lived, meaning you're going to get the effect, and you're going to get the effect for a week, maybe two.
Okay.
Right? And I'm not saying that it's true for all of them, but this is what we see in a lot of chiropractors too, right? A lot of chiropractors focus on a lot of the manipulation component of it, and then they don't follow it with any type of other rehabilitation. So that's why we have all these patients coming to physical therapy telling me, oh, it's because I went to the chiropractor, but I've been going for 2 years and they have me go once a week for 2 years. And it's, just, and this is not by any means trying to bash on the profession.
But I understand. It's just, you're just giving me a quick fix for it, just like taking an NSAID, right? But without really fixing or working on the problem.
And just like there can be very mediocre chiropractors, there can be very mediocre physical therapists as well, right? That kind of just provide the quick fix and then they have the patient coming back. And my goal as a physical therapist is to show you the tools on how you can continue to be successful and how you can continue to prevent this injury from happening in the first place, through exercise and through different mobilizations that you can do on yourself. And so that's why I get a lot of, not a lot, but I've gotten backlash from patients like, I want the ultrasound, I want the dry needling. And I'm like, well, let's wait a second. Let's give this a shot. Let's go ahead and focus on the strengthening component of it and make you independent with that. And then I can go ahead and supplement.
It's like in medicine, like patients come with a viral infection. Give me antibiotics quick and I want, injection so you can just get it over it and go back to work. So no, it's a viral infection. I cannot give you antibiotics. So they get mad because they want, they think that's a solution to go. So, but also, okay, so we're talking that, okay, there are like different type of fixes. But this is also where it comes the responsibility of the runner. It's depending also your commitment that you have to the sport, that you have to really invest your time to become a strong runner. And to become a strong runner, you need to learn how to strength train. You need how to learn your nutrition properly, because also if you have a poor nutrition, your muscles also going to be affected because of your poor nutrition. You're not giving enough carbohydrates or protein to help your muscle recover, and you're putting yourself at risk also for all of these injuries. So because you're saying like, but like different types of therapies and approaches, but I think it's also our responsibility as runners to really pay attention and to learn how to invest in a good program.
And what I tell patients too is, I am your physical therapist that is guiding you to be independent and guiding you to your own recovery. I am not here to solve your life. I am not here to completely get rid of this pain, right? And I'll explain why. A lot of the times when you come into a physical therapy clinic, and especially if you're having to deal with insurance, it gets a little bit messy, and you're looking at anywhere from 4 to maybe 8 weeks that you're getting physical therapy, right? And then from there, it kind of depends on whether or not your insurance will allow for more. Strength training, true strength training, for you to actually have some strength gains, it takes about 6 to 8 weeks of consistent training, right? So if you kind of think about that, you're only coming to physical therapy once, maybe twice a week for a duration of 4 to 8 weeks, depending on a lot of things, right? And your copay and whatever. But strength training, you should be strength training anywhere from 3 to maybe, the more the better, right? But anywhere from 3 to maybe 5 sessions a week, which you're already not seeing that in physical therapy, for one. And for two, 6 to 8 weeks, that's towards the end of your session. You're just starting to see the gains of the strength training by the time you're leaving the clinic.
And I love that you bring this up, because this is going back to muscle physiology. This is how much it takes your body to adapt to new changes or new stimulus or new anything that you're training your body to do. It takes about 4 to 6 weeks to notice a change in your body, to adapt and be able to implement those changes and see an effect. And also, for example, in running as well, right? For example, you need to teach your body, like you see people, I ran this week 10 miles, next week 15, next week 20. No, hold your horses. Wait. Give yourself a time, right? You need to teach again your body, like per week, okay, let's work with 10 miles a week. That's what second week, 10 miles a week again. Third week, 10 miles a week again. Then we come a little recovery, and then we might, however you're seeing, we might increase you to 15 miles a week, because you need your body. You're producing, this is where we talk about stress. You're producing some stress in your body. Some stress, sometimes we think about it as something bad, but stress is just simply that you're teaching your body either volume, either speed, or a strength program, right? You're producing some type of stress in your body, so your muscle needs to, okay, what's happening? What are you doing to me? So you need to allow your body to slowly adapt through maybe a whole month, half a month, and then, okay, let's bring it up. Let's bring it up a notch a little bit. And then, so you can stay injury-free. But it's not that you're not capable of doing more, like taking more weight, taking more volume, taking more speed. It's not that you can't. It's just that you need to respect the physiology of your body to adapt to changes.
That's not, and we're not saying here that there is really nothing happening during this period of 4 to 6 weeks that you initially start training, right? There's the neuromuscular re-education component of it, the synchronization of the muscle fibers. And what that means is you've ever picked up a weight that's too heavy and then you start trembling, right? It's a little too heavy for you. That's the lack of synchronization of the muscle fibers. And so what we try to do during that period of time, that initial period of time, you'll notice that the shakiness will go away towards the end of the 4 to 6 weeks. Why? Because now your muscle fibers are working together to provide that movement. Whereas at the beginning, they're like, oh, you fire. Oh, wait, no, you fire. And then you, right? So that's the physiology of it. You're weak. Your muscle fibers are not working together initially, hence the trembling. And then once they start synchronizing, the movement will become a little bit more or a lot more fluid, right? And that's when we can start to see a little bit more of the strength gain. And from that point, then we can increase a little bit of that weight again, and then you'll see the trembling again. And it's this cycle of going back and forth, the neuromuscular re-education and synchronization of muscle fibers, and then that it turns into actual strength training.
So even muscle fibers need to learn how to work together,
exactly,
right?
Yeah.
So that's very important. Okay, so I guess going back to the injuries that we were talking about. So we were talking about runner's knee. We had the patellofemoral syndrome, patellofemoral syndrome, and then we have the Achilles tendinopathies. We talk about shin splits. Okay, before moving the chain up, we're kind of like in that midpoint. What exercises can help me as a runner? Okay, because we're saying the runner's knee is the most common one, and everybody just complains, oh, it hurts here in my knee, right below it. Runner's knee, right, is a typical one. So how can me as a runner prevent developing a runner's knee? What will be kind of like, if you can tell me typical exercises at least that I should not forget about it?
In terms of prevention, there's no true literature that kind of supports real prevention of really any of the injuries, because it's very dependent, again, on a lot of, it's not like, oh yeah, if you do this, it will likely prevent your runner's knee, because it has to do with a lot of things. We see about BMI, nutrition, lack of sleep, all of that, and then your extrinsic, which would be what type of shoes you wear, everything that's not intrinsic, like yourself, right? External factors, like what type of surfaces are you running on? Are you running on hard surfaces, soft surfaces, uphill, downhill? But in terms of maybe not so much preventative, but things that would, I guess, help you in a sense if you're dealing or could potentially deal with runner's knee or patellar tendinopathy, I would say, again, focusing a lot on the hip abductors, those machines that you see at the gym where you're sitting and you're having to push the plates out, anything like pulley systems that you attach to either your knee or you attach it to your hip, where you're having to open up the leg off to the side, what we call the monster walks or lateral banded walks, where you put the booty bands around your knee. Okay. Good. The booty band exercises where you put them around your knees and maybe around your ankles if you want a little extra challenge, moving side to side. Glute maximus is also very important. Anything like hip thrusts, step ups, the cable kicks, donkey kicks, all of that hip related stuff is very, very good. But again, going back to quadriceps muscles, knee extensions, what are those called? Lunges, stuff like that, that kind of very global movements, squatting, and then depending on the type of squat, right? If you're on a Smith machine, a hack squat, all of that, and the foot placement kind of moves what muscles are being utilized, right? But yeah, anything like very global movement, lower extremity that focuses on hip strength and quadricep strength is super important. But again, not only focusing on the strength component of it, but and focusing on the endurance component of it. Because you're running for prolonged periods of time, you want your muscles to not only be strong for 30 seconds, a minute, 2 minutes. You want your muscles to be strong throughout the duration of your run. So like that exercise, maybe at some point I had you do where you had the booty band and then I had you for like a whole minute, you're just kind of stepping off to the side with the one leg, right? With the booty band around your knees or around your ankles. And doing that for a couple of sets, and then going off and doing something else endurance related, but that is also encouraging the use of that muscle. And Also, talking about the phases of gait, remember how we have the stance phase and the swing phase of gait? You want to mimic exercises that are kind of putting your body through the strengthening component through those phases of gait, right? So there's a bunch of exercises that we could do for that too.
And also for when we're talking about quads and hamstrings and glutes, running up hills and down hills, they involve, even though same like muscle groups, they can also produce, they become like a risk to injury, especially when you're going down hills. Why is that?
That has to do again with the foot placement, right? If you're running downhill, you tend to overstride a little bit more and causing that heel strike, which then causes the forces up into the leg and yeah, the vertical and the horizontal forces that we talked about earlier. It just kind of changes your running mechanics. And if you're not used to that, and then now you go run a downhill and you don't know how to prepare for it, or you're not ready, or your body isn't ready to undergo that kind of stress, that's when the injuries come. So I'm not saying don't do it, but definitely take it easy on the downhills and make sure that you have a solid strength training program for quadriceps, because it also has to do with, and again, going back to the different types of contractions that we have, the isometric, concentric, and eccentric, it changes how that pattern is being used. And going from concentric, now we're doing a little bit more eccentric on the downhills.
Yeah, because I know like when we're going down, it's more like your quads, on that extension of those quads. And sometimes if you don't know how to slow down, that full like stop impact, like also like on your knee, it puts that sudden acute stress on your knee and produces that injury. Because it's very common to see, I was running a downhill, right? So you gotta learn how to take those downhills as well. Yeah,
and your quadricep is taking, your knee / quadricep is taking a lot of that impact with the downhill, right? Going into that eccentric and very high impact type of force going through the knee.
And while going uphill, I guess it's more like your hamstrings, your glutes, putting that strength along with your quads as well, right? Putting that, it's more like a strength workout, right? Like to help you with that uphill.
Exactly. Yeah. So again, a lot of strengthening endurance type of work. And with that comes understanding how many reps should I be doing? How much weight should I be doing? And that's something that I get asked a lot of the times in physical therapy in the clinic. If I go to the gym, how do I know how much I should be lifting? And so then that's when I go into the different components of strength, right? So you have your power, you have your hypertrophy, and then you have your endurance. So the more weight, the lower the sets, you're looking at power, but the more in the middle, so more like anywhere from 8 to 12 repetitions, you're looking at more hypertrophy. Maybe a little bit of strength component, a little bit of power in there too, but then you're looking at a little less weight, but a little bit more sets. Anything above, I'd say 12 to 15 reps with very low weight, you're looking at endurance. Okay, so that's how you need to gauge it. I can't tell you, you need to go and do knee extensions of 50 pounds for X and Y reps. That's going to be very dependent on the patient. I always tell the patient, if we're focusing on hypertrophy, I want you to think about the 8 to 12. You should be able to complete a comfortable 8 repetitions for about 4 sets, but it should be very difficult to go past the 12. Okay, and whatever that weight is for you, then that's what you need to be focusing on.
And again, work on that repetition of sets of that weight for X amount of weeks, like 3-4 weeks, and then go up.
Or if you start noticing, like, I can do 15 or 20 if I wanted to.
That means that it's too low for you, right? So it's better. But you say it's good for endurance.
Right. It's good for endurance. But you also have to know, what am I training today? Am I training strength? Am I training power? Am I training endurance? Am I training, what exactly am I targeting with today? Right? And learning to acknowledge, this is too light for me, I need to go up. And so that's when I ask patients, like, is this too light for you? And then they look at me like, I don't know if I should answer that, because they know I'm going to increase the weight if they can go over 15 reps.
And you can see a struggle right there with the sweat. Look at a heavy workout, right? You think of PT like, it's going to be a nice rehab. No, this looks like almost like a HIIT session.
And again, that's with very exercise-based therapists like myself. I will make you work before I make before you make me work.
Yeah. All right. And I guess going back to, we were talking about all of these injuries. Did we miss anyone?
Yes. Plantar fasciitis.
Oh, yeah, for sure.
Yes. So, the fascia, right? It's an overload of the tissue that's on the plantar aspect of your foot. Typically, we are seeing this in both feet versus just one. And a lot of the reports that we get from people in general, not necessarily runners, we see it a lot out in the community as well. Morning stiffness and morning pain, those first few steps that people take in the morning or after they've been doing something for an extended period of time, whether that's standing, whether that's walking or running, that's the more where the pain comes on the most, right? And a lot of the times these risk factors, again, going back to the intrinsic and extrinsic factors, we're looking at a lot of people with flat feet have this happening. Surprisingly enough, I am very flat-footed, and I always thought, because I always wore like orthotics in my shoes, but apparently like the research says that you really don't have to wear them if you don't have pain. So I go around now with my flat feet, and I really don't wear anything in terms of shoes or inserts or anything, but it can lead to pain in terms of plantar fasciitis. And then other anatomical features such as supination, oversupination, or leg length discrepancy. So one leg can be shorter than the other. Weakness, going back into the hips, or the triceps surae, which would be your calf muscles, your soleus and your gastrocnemius. And yeah, in terms of the integrity of the heel fat pad, right? You really don't need a whole lot of imaging for this. Typically, this can be diagnosed with just a physical therapy evaluation. But a lot of times we're looking at people that are maybe thinking they have like bone spurs or osteophytes that are growing onto their calcaneus, their heel bone. That can also be maybe having something to do
like producing that pain.
Pinching or kind of puncturing through the Achilles tendon, because the Achilles tendon inserts right onto that calcaneus or that heel bone. So a lot of times we need to learn how to differentiate. Okay, does it have to do with the plantar fasciitis? Does it have to do with Achilles tendinopathy, or maybe in even something nerve related, right? Because we have nerves that run through our ankle, and a lot of times they cause pain onto the plantar aspect of the foot. So we need to identify through various tests whether or not it's also nerve related. But something that was very surprising when I was studying during my residency about plantar fasciitis is that there's actually really good evidence for, and this would be really the only one I could possibly think of, in terms of like modality. Well, not necessarily modality, but the bracing. Night bracing was found to be really good in terms of like long-term effects for plantar fasciitis. And I had never really heard of that, but basically you wear this splint or this brace that kind of keeps your ankle into this dorsiflexed position, meaning like your toes are up, because it keeps it stretched overnight. I can imagine it's not the most comfortable thing to wear.
Kind of like a compression?
No, it kind of looks like a boot, like a cam boot, those kinds of boots, or maybe it looks a little bit more like a brace that you see maybe in basketball players that have like the little shoelaces to kind of give stability to the ankle. But no, this one it's kind of weird looking. It kind of pulls your foot up and your fingers, your toes up, because it keeps that plantar fascia in this stretched position overnight. Because when you think about it, when you sleep in a plantar flexed position, and then your toes even curl maybe a little bit, which causes that shortening of the plantar fascia. So when you go and stand, so now you're stretching.
You have to stretch and obviously put this.
So if you put the splint on, you're already sleeping with this extended position of the plantar fascia, and so you wake up and you step in. It should be better, right? In theory, in terms of what the research says, anywhere from the use of 1 to 3 months of these night splints can make you feel better. And with this, in physical therapy, you can expect for us to evaluate your foot placement, right? We use this thing called the foot placement index. I forget the exact name, but basically we score how your feet just naturally stand, whether you have too much pronation, too much supination, do your toes point in, do they point out, and we kind of evaluate that, and going off of that we treat with either mobility, or we treat with strengthening, we treat with the night splinting, recommending the night splints for these patients, and focusing on pain-free movement.
Yeah, and obviously by working some strength in some muscle groups, automatically going to improve your running form.
Exactly. Yeah. So those are the main ones.
What about the IT band? I know. We'll talk about
yeah,
IT
we have
band.
to
That's
talk about
another.
IT.
That's
Yeah.
another. Talking about hips going all the way up to the first floor right there on the hips. They were talking about all the muscles and all of these tendons coming up from the hip. But IT band is a common injury also in runners.
It is a very common injury. And again, the iliotibial band, it's this long band that goes all the way from the hip all the way down to the inferior portion of the lateral knee. And again, this is a lot to do with, you have it in your mind, hip abductors, right?
Okay.
You're going back to the hip. Yeah. And so a lot of the times people think that IT band is always going to be friction related, but not necessarily. A lot of the times it has to do with inflammation of the adipose tissue that's underneath the IT band. So a lot of the focus is going to be pain-free movement, pain-free exercise, cryotherapy. That's when we do a little bit more of the manual therapy and strengthening of the hips, right? A lot of education to patients in terms of, we see it a lot in maybe women that cross their legs a lot and they have this, and not so much IT band, but we also see it in femoral, the name is escaping me. I'll come back to it. Okay. But yeah, we see it a lot in terms of people that cross their legs a lot or do this adduction type of movement. Bursitis, that's what I was thinking about. Yeah, bursitis on the lateral hip. Oh, a lot of education again on pain-free stretching techniques, because we tend to see that the IT band is very, very tight, and a lot of decreasing in terms of the inflammation of the area.
Okay, and then I guess going back to hips, right? Work on those hips. So everything comes from there. So make sure to work on strength on that on your gym, right?
Exactly.
All right. Is HIIT ever advisable for the management of any
HIIT training?
HIIT.
Yeah. Yeah, definitely. I mean, it's a very good way to get that endurance in with some strengthening components within it. In terms of treatment, I don't know that would be my first go-to treatment for any of these things. I don't know that HIIT would be my first one, just because there tends to be a lot of high impact, which is something that we may want to avoid with a lot of these things, especially when talking about patellofemoral pain syndrome and plantar fasciitis. I would say would be the main ones that we want to avoid, that high impact moment. Oh, and medial tibial stress syndrome too, and splints. Again, initially. And then I would say HIIT would be more towards the end of the protocol, maybe towards the end of the treatment for the patients dealing with any of these.
All right, perfect. I guess once we start to recover, let's just say that we actually went through one of these main injuries, right? How long is it advisable to go back and start training? And okay, before that, can I train while I have one of these injuries?
Again, that's very patient dependent, one. But with a lot of these, you are looking for a longer period of time of recovery. So with plantar fasciitis, research says that you're looking up to 2 years dealing with plantar fasciitis. And yeah, plantar fasciitis may come back and, it'll leave and then come back, leave and come back. But you're looking at long-term type of stuff for this. In terms of other ones, you're looking at anywhere from 9 to 12 months for a runner to recover from medial tibial stress syndrome.
Wow, you're giving us like a hard one.
I am sorry. Yes, I apologize. And it depends. Like it just really depends. It doesn't have to get to that. And I'm not saying no, don't run, right? Because you're honestly, why are we kidding? Runners are going to go out and run anyways, right? So I prefer to do negotiate and come up with a plan that may help the runner continue doing what they love, but at the same time not have to push recovery to be 9 to 12. Right?
Go easy, do on your easy walk, jog.
Physiologically speaking, it may take that long for the tissue to recover.
Of course.
That's just what it is, right? But we can work together to make something work, right? Because we need to keep that 2 out of 10 in mind whenever we're in training. And you need to be honest with yourself. Like, does it hurt more than 2 out of 10? Then I need to stop. Because I really want to run, but is it worth it for me to run now versus me to do, this protocol and listen to my body and then maybe a full marathon later? You have to kind of think about the long term.
Yeah, and I need to tell to my runners, right? When they tell me that they have like pain on my knee, and so stop. Go get evaluated first before you even start like training, because before going into volume or not knowing that I can give you speed workout, like it's just gonna head and develop into a full injury, like for sure. Not for sure, but like if there's like you're already carrying some type of like risk and you're already experiencing some type of pain, might as well stop, work on your strength, work on this, and then you start to working on bringing the volume up, or start training for faster races. And I know I don't know if you can tell me, this is some of the rules for managing injuries for coaches, rules of thumb. So it says if you miss, let's just say that you have pain and you miss 1 to 3 days of training, you can probably get back into training without any setbacks. Yeah, we're good. So if you have some type of pain and you miss 1 to 3 days, you're good to go. You probably can go back into your schedule, and that's okay. If you miss about 1 week, right, it's advisable for you, because sometimes runners, they want to go back into their usual schedule, the training, the volume, the speed workouts that they were having. So it's advisable that you had to take about a week off, and also going back to your physiology, right? You're going to have to spend about 4 to 5 days back into easy running before thinking on and going back to your previous schedule. If you miss more than 1 week of training, perhaps spend equal amount of days doing easy mileage as missed during injuries. So, and if you miss more than 1 month, you're gonna go back and start back from a base phase, right? So, I guess it's very important for runners. Do not overdo it. Do not be smart, right? This is where your knowledge and understanding the physiology, understanding the impact that an injury can have on your body, and be smart about it. It's important for us to pay attention to strength, to diet, for recovery, to sleep, to any other type of stress, because all of that is going to affect your body as well. I think all of that is very important. So any other takeovers that you think is important to mention to the runners?
No, just listen to your body, be true to yourself, be conscientious about what you're feeling, and really take it into account. Listen to your body, and remember that pain doesn't necessarily have to be only during your session, but it can also come after. So if you're having that pain, not necessarily during, but after your run, that's also a red flag, and you need to take it into account, because it's not normal. Okay, so that would be my biggest takeaways. Listen to your body, be willing to put in your part in terms of the strength training, and don't neglect your hips.
And Dr. Lily, if one of our runners would like to reach out to you, where can they find you?
They can find me on my Instagram. I'm under Dr. Lily De Castro on Instagram. My little logo says Functional Anatomy on it. You can go ahead and reach me through there and send me a message, and we can get to chatting.
Or reach out to me. I'll be more than happy to put you into contact with Dr. Lily. She's an amazing therapist. She's knowledgeable. She's smart. I've been her patient, so I know she has helped me in the past. So make sure to check her out if you guys need some, or if you have pain, get an evaluation. Make sure to pay attention to your bodies. I think that's the main takeaway that we can say from here. Pay attention to your body. Be a smart runner. Do not neglect pain, inflammation, any signs that your body is giving you about too much stress that can lead into an injury. Take care of it. Also be a responsible runner. Work on your strength, like follow those advices. Recover, rest, make sure to sleep, make sure to eat well, make sure to work on your strength so you can become a better runner and perform well. And that's right. Pretty much the goal, right? All right. Well, guys, thank you so much for listening. I love this podcast. Thank you, Lily, for being with me today. I love this information. And if you guys have any other topic that you would like me to discuss or bring a health expert on that, make sure to let me know. If you have an event that is coming up and you would like me to share on the podcast, also please make sure to share with me, because this space was made specifically for you. All right. Thank you, guys. Have a good day.